Well, first of all, thank you everyone for showing up tonight for this presentation. I've been excited about this for months. And I'm super grateful for Dr. Ko for coming to talk with us about his work with ketamine, which is something that we as Yale Psychedelic Science Group have been talking about and listening to outside speakers for years now. And I'm very excited to hear Dr. Ko talk about his approach and his journey using ketamine. Just as a bit of background, I actually met Dr. Ko back in early 2016, before I even started medical school. And I was really like in a personal way, I was very inspired that there was someone with an MD after their name who was interested in using psychedelics as part of clinical care. At that time, I felt like a lot of folks were kind of in the closet about that, and to meet, someone who was a physician who was, and motivated to do this kind of work, it was for me inspiring, because I thought I was like one of the only people alive, not really, but there weren't many of us out there talking about these things. And over the years, staying in touch with Dr. Ko, hearing about, when he had this idea for starting a ketamine clinic years ago, and now that's become a reality. So I am super inspired by his own journey, from when I first met him 5 years ago to where he is today. I think he's doing really great work, having talked with him and other people about what he's doing. And so I was really motivated to have him come speak to us, because I think he brings a valuable perspective that we don't hear a lot about, which is both the perspective of someone who is motivated to help people heal from whatever's ailing them, but also has a little bit of financial and business savvy, if you will. Sam's got this entrepreneurial spirit, or Dr. Ko has this entrepreneurial spirit, and he's kind of been in the trenches doing this as a business owner, which is, I think, something that is going to become more and more the norm, as whether it's with ketamine or psilocybin or MDMA or whatever else might be coming down the pipeline. And so learning from folks like Dr. Ko, who are establishing these businesses to help people using ketamine or whatever other psychedelics are at their disposal, I think it's something that I know we in the leadership are really excited to learn more about. And I think it's going to become more and more a topic of conversation. So that's a very long introduction. I want to turn things over to Dr. Ko and just thank him again so much for coming to speak to us today.
Awesome. Thank you, Rob. And it is an honor to be here at the Yale Psychedelic Science Group. I am super excited to give this presentation. And, there's a little QR code on the website. So if you want to get access to the slides and some other stuff, some downloads, you can go in and take capture that with your phone. And then that way you'll just have access to all of the slides. Pretty easy for you. And let's get started. So here's what we're going to be covering today. It'll be 3 parts. Part 1 will review the current state of depression and the psychedelic community and the Renaissance. Part 2 will be discussing turning the actual research into clinical practice. And this is where I'll share with you my journey about opening up a ketamine clinic. And then part 3 will be our approach to ketamine infusions and some case reports if we have time for that at the end. I want to leave plenty of time for Q&A and discussion, just in case that you may have some questions near the end. A few disclosures before we begin. First off, this is going to be a discussion of ketamine for off-label use. And so that's just one thing just to get out of let you know about. I am also the founder and medical director of Reset Ketamine. It's in Palm Springs, California. I'm also the co-creator of a course called Ketamine Startup. It's an online course for physicians. And lastly, this presentation is not a substitute for getting professional legal and accounting advice for any startups that you may decide to pursue. So let's jump into it. Part 1, the current state of depression and psychedelics. So depression, and this is a really important topic because according to the World Health Organization, depression has now surpassed HIV, AIDS, malaria, diabetes, and war as the leading cause of disability worldwide. 16.2 million Americans have experienced a major depressive episode. Depression is much more common in females than males, about 8.5 versus 4.8%. And some studies are reporting that up to 20% of teenagers actually experience depression even before they reach adulthood. And there's also just in general increasing prevalence of depression in both adults and teenagers. And what's especially concerning these days is COVID-19 and its impact on our mental health. There's increased loneliness, isolation, there's fear of friends, family catching COVID-19, there's employment uncertainties, as well as increasing rates of depression, anxiety, and substance abuse. But one of the major concerns with depression, of course, is that it can lead to suicide. About 800,000 people die by suicide every year. And according to the CDC, the national suicide rate has increased 33% from 1999 to 2017. Suicide is also the leading cause of death, or excuse me, the second leading cause of death for Americans between the ages of 10 to 34 years of age. And believe it or not, there's twice as many suicides as there are homicides in the United States. And right now, we're kind of at this place where the suicide rate is at a 50-year peak in America. And so what is the traditional current mainstay for treatment? And those are SSRIs. And as you may or may not know, SSRIs, they're about effective in about 33% of patients. They can take weeks to months to kick in, and there's significant side effects, loss of libido, weight gain, insomnia, anorgasmia, and even suicidal thoughts. And studies have shown that patients who take SSRIs, there's actually a 33% higher mortality rate than those who don't. And what does this lead to is that we need more options available to us. And as you're well aware of, there is an explosion of psychedelic research going on with MAPS, Imperial College of London, Johns Hopkins, Harvard, UC Berkeley, NYU, and Yale. And we're studying substances like MDMA, psilocybin, LSD, ibogaine, ayahuasca, and 5-MeO-DMT. And we also know that the psychedelics are becoming more recognized and more common. So for example, Michael Pollan has his books, How to Change Your Mind. This is Your Mind on Plants that was released recently. And so this is definitely in the zeitgeist. Unfortunately, one of the biggest challenges that we have is all of those substances that I've mentioned are currently classified as DEA Schedule 1. That means that it's not readily available for our patients in the clinical setting, mainly just in that research area. So given this situation, what is currently available? And this is ketamine. And as you're aware of from previous presentations, ketamine is a really old drug. It was invented in the 1960s, and FDA approved in 1970. It's probably the most commonly used medication for sedation worldwide. And the World Health Organization considers it one of its most important essential medications for a hospital to have. And more recently, starting in the early 2000s, there's been reports, initially these small studies where they're looking at the effect of ketamine for depressed patients, as well as for suicidal thoughts. And since one of the first studies published by Dr. Berman, in the past 20 years or so, there's just been multiple publications coming out, leading to meta-analyses like this one, more recently published last year, December 2020. This is a systematic review and meta-analysis of the efficacy of IV ketamine infusions for treatment-resistant depression, where they just looked at all the articles. And the bottom line is that they found ketamine can be an effective alternative for treatment-resistant depression. So given this research and all of the data, how do we actually turn it into a clinical practice? And this is where I want to share with you a little bit about my journey, about how I started at the clinic. So in medical school and residency, we're taught about anatomy, biochemistry, pathophysiology, differential diagnoses, treatment plans, but we're not really taught how do we create our own medical practices. And what's interesting is that a recent study by the AMA showed that the vast majority, 47% of practicing physicians these days are employed by a large healthcare organization versus about 45% who own their own private practices. And what I make up is that this loss of autonomy can contribute significantly to burnout. And I think burnout is one of the major challenges facing the healthcare industry. And when doctors, they don't have that freedom to practice the way they want to, it can contribute to this. And there's this great quote that the three most harmful addictions are heroin, carbohydrates, and a monthly salary. So as physicians, we're kind of caught with these golden handcuffs where we're going to get paid really well, but at the same time, we may have these large student loans or other financial burdens that prevents us from doing our own thing and taking ownership of our practices. So for me, given the golden handcuffs, I had to start with knowing my why. And this is, if you're considering starting up a practice, you really have to know, like, well, why am I doing this? And for me, it was a combination of that autonomy, combination of freedom, combination of practicing the way I want to practice, as well as this concept from a Japanese word called ikigai. And ikigai refers to living your life purpose. It's a Venn diagram combining 4 circles: what you love, what the world needs, what you can be paid for, and what you're good at. And so for me, knowing my why, this ikigai, knowing that this is a part of my life purpose, a part of my dharma, really contributed to the obstacles that one faces as I started up the ketamine clinic. So think about this when you're going to first start a clinic. It's like, well, why am I doing this? What's my goal? And how does it align with my life purpose? The second thing is to create a name and a logo. This is really important. My wife and I recently had a baby in the middle of the pandemic. And one of the first things for those who have children or any, pet, for example, one of the first things you do is create your name, create a name for it. So this is step 2, is creating a name and a logo. The logo is almost like a visual representation of what your vision is, the mission and the values. And let's talk about Reset Ketamine's logo just as an example. So we have the reset button in the middle. Ketamine potentially resets the default mode network, and we believe our patients are naturally creative, resourceful, and whole. And our goal is really to help kind of reset our patients so that they can go back to living a whole, healthy life. The second component of the logo is the wings. And so this is kind of about kind of the freedom that one will feel after getting their ketamine treatments, and also kind of that psychedelic experience that one may experience during their ketamine infusions. Step 3 is to write up a business plan. So step 2 was about name and logo. It's kind of like right brain activity. And then writing up the business plan is really important, especially if you're going to be getting investors for your clinic, or if you're going to be getting a bank loan. That's one of the requirements for getting financial funding. But even if you're not planning on getting an investment from investors or VC or getting a bank loan, like just doing the exercise is really important, because that's going to provide you an opportunity to like logically think through each step. You're going to come up with any weaknesses or just any opportunities. And again, if you go to that QR code, you'll find I put in a business plan template specifically for ketamine clinics, so you can download that at the website. After that, you're going to want to incorporate your clinic. And this is something, again, that we're not really taught in med school / residency. How do I actually just incorporate a clinic? And one of the important things to do that, you want to incorporate your practice, because that's going to separate your personal assets from the business and clinical assets. And once you incorporate, and there's various incorporations, you can have an S Corp, a C Corp, an LLC, and that's something that you're going to want to discuss with a business attorney. So once you've incorporated, then you can obtain something called an EIN. It's kind of like a social security number for businesses. And from that, you can create bank accounts for your business. And once you do that, now you're able to enter agreements and contracts under the business name. Step 5 is to find a location and sign a lease. So some of the factors that you want to consider when you're opening up and finding that perfect location, you want to think about the patient demographics, competition, if there's other clinics, proximity to other medical practices, and how visible that clinic space is in regards to, is it a high traffic area, is it a low traffic area? This is kind of a crucial juncture because when you sign a lease, this is when you really have skin in the game, because you're going to sign a lease for a 1-year contract, a 2-year contract, a 5-year contract, a 10-year contract, possibly. And you're going to sign your name and you're going to say, hey, I'm going to lease the space, or there's going to be consequences afterwards. Also, when you get your location, there's going to be initial investments for building out the space. And that's where you're going to put in multiple thousands of dollars into it. And so having the skin in the game is really important. It's a pretty major step. And for me, this was kind of an area where I was just putting money into the clinic, and there was a bit of fear, to be honest, because it's like, hey, what if I open up this clinic? What if no one shows up? What if I sign a lease and I have to break the lease? Or how am I going to end up paying for this? But there's something really powerful about having your skin in the game, because then it's like, I'm going to make this happen no matter what. Step 6 is to get insurances. And I know probably the most common one you're thinking about is like malpractice insurance, but there's other insurances that you need to have: general liability, commercial property, workers' compensation, business income insurance, etc. And there's a host of insurances. One of the major ones, of course, is malpractice insurance. And when I started, this was about 3 years ago, ketamine infusions were pretty new. And this was one of the challenges that I had, where I talked with an insurance broker and he shopped it around to all these different insurance companies. And they came back and they said, hey, we're not going to cover you. And that was pretty devastating, because obviously I need malpractice insurance to begin the clinic. So this was where I had to get a bit creative and reframe it in such a way that, hey, I'm going to face this obstacle. And this obstacle is actually a way for me to prove how badly I want it. And so when you're starting up something new, there's going to be obstacles, and it's all about reframing it. So what I did eventually was I contacted one of the insurance firms and I asked to speak with their senior underwriter. And I literally had like a 90-minute conversation with her saying, hey, these are the details. These are the studies. This is what we're planning to do. And she was able to get like kind of an audit and bring it up to the committee, where they were able to discuss it. And ultimately, a week later, I get an email saying, hey, you're now approved for malpractice insurance coverage. After that, you want to buy your supplies and your medications. And here's some of the things you're going to need are IV fluids, IV setups, the machines, sharps like IV catheters and needles, syringes, medical equipment, tapes, gauze. And these are all things that normally I never dealt with, right? There's always like, who's ordering gauzes, or who's ordering bandages, or who's ordering syringes? Like for us in the medical field, traditionally, like that's already taken care of. But as a business owner, you're going to need to know, hey, where do I buy this? Where do I source this? And fortunately, there's firms like McKesson and Henry Schein and just various medical manufacturing companies who can supply that for you. So it's something that you're going to definitely consider. And once you do that, boom, you've signed your lease, you've gotten the medical supplies, and this is a picture of me and my wife. And this is, we're super proud, super happy, very excited. We're actually going to launch this thing and make it happen. And so let me, in this last part, let me share with you our approach to ketamine infusions and some case reports. So here's our clinic, and there's our logo. And, we really start with the definition of health from the WHO, and they define it as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And, I did my training at University of Rochester in New York, and that's where the biopsychosocial model was founded. And also I added the fourth component, which is the spiritual aspect. And so biology, referring to like subatomic particles, atoms, DNA, epigenetics, cells. Then you have the psychology, the mind, the conscious mind, the unconscious mind, life experience, behaviors. Social relationships with your partner, friends, family, community, society, earth, and that spiritual component of a human being to what transcends the human body. And so that's kind of the framework that I take as we do the ketamine infusions. And one of the other things to consider is, we talk a lot about like mind and body. And one of the things that I'm learning is that it's all connected. And so here's the map of like Arizona, California, New Mexico. And if you go to Google Maps, there's like this clear delineation, like here's Arizona or here's California. And you'll see like this thick red border, right? But when you actually go to these borders, there's nothing there. There might be a little sign. And again, this is really important to understand that the connection between the mind and the body and the spirit. There, although we call it different things, we have different labels for it, we've kind of reduced it to these lines. It's all actually interconnected. And so one example of this is Takotsubo syndrome, where also known as the broken heart syndrome. And this was a case report based out of Japan where a patient experienced a severe emotional loss. She felt like she had a broken heart. And so she goes to the emergency department. They see ST elevation on her ECGs. And when they take her to the angio, her coronary arteries are cleared. And they're like, what's going on? So when they did an echo cardiogram, they found that she actually had this abnormally shaped ventricle, where you have on the image, you have the normal left ventricle, but this abnormally shaped enlarged ventricle, and which looks like a octopus trap. And so this is where the name Takotsubo comes from. And this is just, again, an example of where, these emotional experiences we have can create these physiological changes to our organs. So going from that framework, there's 4 phases of ketamine infusions at Reset Ketamine. The first one is preparation. And this is where we tell our patients, even before the ketamine infusion, for 5 days before, you want to start doing these healthier practices like meditation, journaling, being in nature, avoiding violent movies, avoiding pornography, avoiding any triggers. And so really to get the mindset in place. The next phase is the intention. And so being really clear on what their goals are prior to the ketamine infusion and focusing on that throughout the experience. The third phase is having the experience, experiencing the experience, being with the ketamine infusion as it goes. As you know, it creates these non-ordinary states of consciousness, and we really want the patient to be connected with that. So we have like eye shades and headphones, so it's really like an internal experience, not as much talking, so the patient can really connect with themselves. And then the fourth phase, which is integration. This is really crucial for ketamine and just for any psychedelic substance in general, is like, how do I take these transcendental, profound experiences and bring it home into my daily life? So a few case studies. We'll go with patient A. He is a 55-year-old male. He has a history of treatment-resistant depression. He's tried SSRIs, SNRIs, not really working. And he came to us for the treatments. And one of the things that we do at our clinic is measurement-based care. So with each infusion, we give them a PHQ-9 so that they can, we can assess how they're doing. And so when he first came in, his score was a 17. And with each progressive infusion, it decreased. And what's interesting is by the end, his PHQ-9 was less than 5. And he said afterwards, my depression is simply gone. Now I can mold my life the way I want it. And I can't remember when I felt so good. Thank you so much for your help. I feel like I have a future now. I think I emailed him about a year afterwards, and just after that initiation portion. And he told me, hey, I actually started a new job. I am, just doing great. I'm feeling better. And what was interesting was like how long lasting it was. It's not for every patient, because some patients frequently need maintenance infusions, but for this patient, it was doing really well. The second patient is a 43-year-old female military veteran. She had anxiety, she had treatment-resistant depression, PTSD, chronic pain. And with her, she was in the military for many years. And what was interesting is during the ketamine infusions, one of the things we do, as I mentioned, is like these blindfolds. And with each infusion, like they were just covered with tears. We had to like replace the eye shades each time because it was literally like drenched. And when we were talking with her, she told me like, hey, for 20 years, I never cried. I was in the military. I grew up kind of with this machismo culture. and I was not allowed to cry. Like, that's just frowned upon. And during her ketamine infusions, she just released all of these tears, all of these emotions just came up to the surface. And as you can see, her scores went down from, she was like a 22 and then to a 15, which is a significant improvement. She told us afterwards, she says, hey, just to follow up, I'm feeling good. I had a good session in my doctor's office. She said my numbers, they haven't looked so good since I started counseling with her. She also had chronic pain, and this is one of the other reasons we were giving her the ketamine infusions. She said, hey, I don't need as much Percocet, I don't need as much Neurontin, and she felt like she was sleeping better. And we have patient C, who is a 49-year-old male, history of depression and social anxiety. This patient had actually tried TMS, transcranial magnet stimulation, and I think he did like 30 sessions, no real improvement. So he came to us, so also treatment resistant. And if you can see here, his initial PHQ-9 was about a 17, and with him, it went down to a 7. He says, this is the first time in my adult life that I feel something is actually changing. He said, hey, I had a great weekend. I've also noticed a big improvement in my ability to talk to people, and I'm feeling more desire to connect with others. So feeling really excited and hopeful. And for long-term follow-up for him, I think he was one of our earliest patients, and he came back for booster infusions about 2 years after his initiation series. And yeah, he had made significant changes in his life. He had sold an old property that was causing some stressors for him. But he did come back for boosters, which were about 2 years after the initial series. So to summarize, what we covered is the part 1, the current state of depression and psychedelics. Depression is a major issue in America, in the world, can lead to suicidality. And psychedelics, this renaissance is occurring, and there's a lot of research. And the question is like, well, how do we take that clinical research and put it into practice? And so now you know some steps about, hey, what are the things that I need to consider as I'm beginning my own practice? And then lastly, I'm discovering more and more that ketamine is just one part of the treatment. It's actually, I believe, one of the things that helps our patients is kind of having this biopsychosocial spiritual framework and this integration component and preparation. Because, there's different models, and there's other ketamine clinics out there, and there's this huge diversity of how it's done. But I believe that having this framework, having more of a holistic approach, can be incredibly beneficial for our patients. And again, I think this is our last slide. So again, you can go to that QR code, go to the website, and on there, you'll find like all the slides, you'll find the business plan template, as well as a checklist to like start up a clinic. And I think that's it. So I want to open it up to Q&A, and I'm happy to answer any questions that you may have.
Awesome. Thank you so much, Dr. Coe. We really appreciate you being here and giving that presentation. So Q&A, most of you probably already know the rules, but just raise your hand. I'll call on you, I can unmute you. And then if you wouldn't mind, and if you're okay with it, we'd really appreciate if you turned on your camera so we can see your face and have a little bit more of a conversation. And then you can also put your questions in the chat and I'll read those as well. So we will start with Rob Palmer.
Sorry, there we go. Sorry, calling you from the back of a VA shuttle bus. Dr. Coe, first of all, thank you so much for that talk. I have so many questions, but I guess one of the questions I was especially curious about is your route of administration and dosing, or, because there's so many different approaches out there, whether it's intravenous or intramuscular or lozenges or some combination of the above. And actually I read on your website, you have an article explaining why you chose the approach that you chose, at least at that time. I don't know if things have evolved since, but I'd love to hear you talk about your thinking, both in terms of like the therapeutic value of the approach, but also I think there's the sort of like the logistical and practical matters too that sometimes people overlook. You know, they're thinking strictly in theoretical matters and aren't taking into account, you know, the on the ground perspective. So I'd love to hear you talk about that.
Thanks, Rob. Great question. And I really appreciate you bringing that up. So yes, there are different routes of administration. There's IV, there's intramuscular, there's intranasal, there's oral. My focus is really on IV. And the reason is it's 100% bioavailable. So if I put in 50 milligrams of ketamine, I know 100% of that is going to be administered. Whereas with the other routes, it's a bit less. So for example, if someone is getting intramuscular, it's about 90%. And it can vary also. So if they put the needle into, you know, part that's more fatty, more muscle, then it's going to create different bioavailabilities. And then with like oral troches, I think it's like around 20 to 30%, depending upon, you know, saliva content and all these host of other factors. But I really want to use the minimal effective dose because although ketamine is safe, it can cause issues, right? There's been reports of ketamine-induced urological tract dysfunction, ketamine-induced cystitis. It can cause liver inflammation. So some of these things was what was playing into my mind as I'm deciding which route. One of the things that I love about IV ketamine is because it's delivered intravenously via an infusion pump. So it's slowly administered. And a lot of studies are going for like 0.5 milligrams per kilogram. And that's what I typically start at, is that dose. But on the like really doing it in the clinic, I increase the dose. And so with each session in general, I'm increasing the dose 0.6, 0.75 mg per kg, 1 mg per kg to get a really good effect for the patient. And the nice thing about IV is because it is slowly administered, I know the exact amount, I can stop it at any time. So if a patient is having some sort of reaction or they want to stop it, I always tell patients, it's like, hey, you can get off the ride at any time. And so all I need to do is hit stop on the infusion button, and then the effects of the ketamine will rapidly fade. In addition, when you have an IV, ketamine can frequently cause hypertension, it can cause nausea, it can cause anxiety. And because I already have IV access, I'm able to administer benzodiazepines if needed. I'm able to administer, you know, beta blockers if needed. I'm able to administer antiemetics if needed. So it's just like having that access to different medicines. It's really important. And the other thing I didn't mention is, you know, one of the things that we do at our clinic is we are continuously monitoring our patients' vital signs. So I'm looking at their cardiac rhythm, I'm looking at their pulse ox, I'm looking at their blood pressure, I'm looking at, you know, their respiratory rate. And one of the things that I've seen is hypoxia. And I know historically we believe ketamine, in general, it is safe. It doesn't create respiratory depression. But I have actually seen it slow down patients' respirations where they're breathing, you know, 4 breaths per minute, and their oxygen level will drop. Fortunately, because we are monitoring them, I'm able to administer supplemental nasal cannula oxygen, and then their saturations will go right up. I think, you know, regarding the other formulations, there's a lot of things that are happening now, especially with like low dose home ketamine, where there's like different companies, Field Trip Health, Mind Bloom, various startups where they're doing at-home lozenges. So this is an area for research. There's not as much robustness of data though, because all of the studies that are being done, whether it's at Mount Sinai or Yale, it's predominantly done intravenously. And then the last thing that I do want to touch upon is, you know, in addition to mood disorders at our clinic, we're treating patients frequently for like pain disorders. So like complex regional pain syndrome, trigeminal neuralgia, fibromyalgia. And with those, you're going to need a higher dose, a longer duration. And again, with the higher dose of ketamine, that can lead to additional side effects that we want to watch out for.
All right, next, Robin Martin.
Hi, I'm Robin, everybody. First, I really want to thank Rob and Will and the Yale Psychedelic Group for having this. And Dr. Ko, I really appreciate you joining. I really liked your expansion of the biopsychosocial model into the biopsychosocial spiritual model. And I really appreciated your emphasis on, you know, preparation and integration and the experience itself. I think that that's really lacking in a lot of ketamine clinics I've seen. Rob kind of stole the sales from part of my question, but I just graduated residency, and I'm planning on joining a private group practice of young, you know, mostly child psychiatrists. They do a lot of family therapy. They have a TMS clinic there. They have a lot of adults that they want to treat there. So I'll be joining them as a general adult psychiatrist, and they're very open to me starting a ketamine clinic there. But I have, you know, but basically it's a psychiatry group. They don't have any experience in that. So I'm kind of like, so I really appreciate your guidance, because this is like the exact kind of thing that I'm needing right now. I'm curious, you know, as a group, like, I mean, I wonder if you could expand on like the practical considerations of being, you know, for example, I've only had my primary psychiatry training. I'm not an EM doctor. I'm not I didn't train in anesthesia. Do you think in order to get those kind of malpractice coverage and stuff like that, would I need to do additional training or be prepared to like deal with certain medical complications that could arise?
Yeah, great question, Robin. And I'm very excited for you because, and this is a really good question. There's, in general, right now in the ketamine clinic space, there's probably 3 specialties who are doing ketamine infusions. And as you've mentioned, anesthesia, emergency medicine, and psychiatrists. And so right now what's happening is psychiatrists are administering ketamine and they are being covered for malpractice insurance. Now, one of the things to note is that when you are using it for mood disorders, it's typically a lower dose, right? So you're doing 0.5 milligrams per kilogram in general when you start, and versus like when you're doing it in the OR or ER, we're pushing 1 to 2 mgs per kg over a really short period, 1 minute, 2 minutes. So it's like this really blast off. Now with the ketamine infusions, it's a lower dose to start with, and it's slowly infused over a 40-minute-ish infusion, right? And so because of that, there's less concerns for significant side effects. I think what would be most important for psychiatry is to have to monitor their patients, because like I mentioned, you know, the O2 saturation can frequently drop. And although you're a psychiatrist, you're still a doctor, and you know the biology. You've done your intern year, and you have that medical background. So I really believe that psychiatrists can provide low-dose IV ketamine for mood disorders. Now, if we were to consider something like CRPS, complex regional pain syndrome, for those patients, I'm treating them for like 4-hour infusions with a really high dose. And so, you know, I'm thinking about my psychiatric colleagues, and they're not really entering that pain category for patients. They're more entering the space of like mental health, mood disorders, depression, PTSD, anxiety. And I think that is totally within the realm of capacity for psychiatry.
That's pretty reassuring. Thank you.
Yeah, and the other thing I do want to mention, Robin, is there's a lot of evidence or not a lot, but there's more evidence coming up for teenagers with ketamine and depression, especially with treatment resistant. And so at our clinic, I have treated 17, 16-year-olds at the youngest age. And I know other clinics, they've even treated like 12 to 13-year-olds. So that would be another possibility. And I've treated, because we're in Palm Springs, California, which is kind of like a retirement community, I've treated 78-year-old patients with IV ketamine. And of course, with those, you know, 2 categories, I'm being really conscious of the dose, you know, probably even lowering the dose in some cases because they're more sensitive to the medication, and being really cognizant of how it's affecting their vital signs. And of course, working with their psychiatrist, because my background is in emergency medicine, but you know, my expertise is not mood disorders. So I really love kind of a team-based approach where I'm collaborating with the psychiatry, with their therapist, so that it can be, you know, teamwork. And again, ketamine is just one part of it, and kind of that integration and talk therapy, whether it's with their psychotherapist or a coach or whatever it may be, it's really important as well.
Yeah, I'm curious about those collaborations, and and just to follow up on it with a question, if I may, you know, looking at the economic model. Like some of the people are starting to do Spravato. I've heard some of the local providers say that it's hard to make money doing that because of the REMS. The requirement for the REMS is particularly kind of burdensome. So some people are doing like these sort of group sessions to try to lower the costs. As a psychiatrist, I could probably bill for the therapy component and the evaluations, but would probably still be charging cash for many of these treatments. But I'm wondering if you have any thoughts or tips around that, maybe how to approach those issues.
Yeah, great question as well. So for those of you who don't know, there's Spravato, aka nasal S-ketamine. So ketamine has the two. It's a racemic containing R-ketamine and S-ketamine, and Johnson & Johnson, they took out half of it, the S-ketamine, and created this nasal spray. And I think each nasal spray is about like $800 or $900 per spray of S-ketamine. And so the cost is it's very high. And I would say probably even higher than just getting, just paying out of pocket for an IV ketamine infusion. I think the average cost for an IV ketamine infusion is about $500-ish. But then compared to like one dose of of intranasal Spravato, it's really high. Now that is covered by insurance, and the patient and the doctor, they have to go through various hoops to make that happen. Like the patient have tried multiple antidepressants, they need to be on an antidepressant. And one of the things about the S-ketamine is there was a meta-analysis systematic review that just came out, I believe this year or last year, and they compared intranasal S-ketamine Spravato with IV racemic. And what they found was that the IV racemic ketamine was far superior than the intranasal S-ketamine. And there was another interesting rodent study where they gave either S-ketamine or R-ketamine, and they found that it was actually the R-ketamine that provided more of the antidepressant effects and for a longer period of time. And so, yeah, it's Johnson & Johnson, they're a big company. Their goal is to maximize profits for their shareholders. So I totally get it. But I think this is one of the reasons why we need to have this generic IV racemic ketamine available, just because the evidence shows that it's much more effective. And the other point is regarding health insurance coverage. And I believe Massachusetts Blue Cross Blue Shield, they just recently started covering IV racemic ketamine. And from a health insurance perspective, they're like, well, do I want to pay, $800, $900 for, Spravato, or pay less and get a more effective response? And so this is slowly transitioning where insurance companies are beginning to cover IV racemic. And again, because you have that psychiatric background, I know of other clinics where they are billing the insurance company because they're in network and they're billing for the psychiatric component, but then the patient is paying out of pocket for the infusion. So it's, the patient is still paying some, but not as much because a portion of it is being covered under the psychiatric billing codes.
I had a quick question. I was wondering if you could talk a little bit more about how you do the integration, or how you do the preparation, how you do the integration, and then how this sort of biopsychosocial spiritual approach gets woven into all of this. A little, maybe more of the specifics. I think people would be interested to know a little bit more about that.
Yeah, so as you know, with psychedelics, set and setting is really important. And so, I have a list of guidelines, like 12 different things that I tell the patients to do. Just send them a PDF and say, hey, these are things I want you to focus on. And that looks like doing things that are going to help them, specifically, journaling, exercise, eating healthier, avoiding social media, avoiding news. And so they're following those guidelines as best possible, right? Like no one's going to be able to follow it perfectly, but I say, hey, do this as much as you can. And throughout the series of infusions, continue doing these practices. So like, for example, we had one patient, one of our recommendations is like no alcohol for 5 days before your treatment, and throughout the series of treatments, actually. And so it was really great because he did that preparation. And then by the 6th infusion, I noticed that his blood pressure was like normal when he first came in. It was always like slightly elevated. And I said, hey, what's been going on? He's like, oh yeah, I haven't drank, for like 3 weeks and I'm feeling really good. So that's part of that preparation. And then the tail end of the integration this is probably one of the most underrated aspects of ketamine therapy, is like they've had a transcendental, ego dissolving, possibly even a near death experience. And it's like really out there. So how do I bring that into practice? And so one example would be, someone like stopping drinking, or I had another patient who started going to church. I didn't tell him like, hey, you need to start going to church. He already had that background. And so he's like, yeah, I've just started going back to church. And so I think about integration, and someone once said like integration is doing homework, doing what you need to do. And because we all kind of know what we need to do, and having the patient do it is really helpful. And ketamine seems to be like a catalyst, because ketamine works via, blockade of glutamate activity on the NMDA receptor. And ultimately downstream, that leads to increased brain-derived neurotrophic factor. And we know that that increases neuroplasticity. So what's great about the ketamine therapy is they kind of get unstuck. And so they're incorporating these new habits and these new beliefs. And that's going to help with the integration, because they have that neuroplasticity from the ketamine therapy.
Okay, so it sounds like it's kind of guidance you're giving to them, things to do before, things to do after. Is there any sort of like integration with therapy afterwards, like with the psychologist, people like that to meet with and to sort of process what might have happened?
Yeah, so I know some clinics are doing psychotherapy during the infusion, ketamine-assisted psychotherapy. And, we don't really focus on that, because we want the person to have the experience rather than be externally focused, looking out, being out. We really want them to go in. And what they'll do, though, that coaching or therapy session is really important, because, for example, they can just journal their experience, write everything down, or they're going to remember it too. They'll schedule an appointment with their therapist for the next day, and then they're going to say, hey, I remembered I had this memory of, my dad, or I had this memory, this traumatic thing that came up, and I totally forgot about it, but the ketamine just seemed to bring it up to the surface. And we really recommend that they schedule an appointment with their therapist, and so that they are able to decompress and process. I think what's really profound is, meaning making. Humans are meaning making machines, right? And it's like, all right, I had this intense experience. What's the meaning I can make from it? And with a therapist, if they're able to facilitate that meaning making process, I think that can be a really important part of that integration.
Okay, great, thanks a lot. All right, I will toss it over to Mohammed.
Hello, can you guys hear me? All right, cool. So thank you so much for the incredibly informative and practical information. I really appreciate it. My question, I guess, looks a bit ahead, a decent amount of years. So once other psychedelics like psilocybin, MDMA, ibogaine, LSD, kind of gain traction and become approved for clinical use, how realistic do you see kind of like this general psychedelic clinic being established? Like, do you think you would have to have an establishment for like specifically ketamine or specifically psilocybin, or do you think it's possible for there to be like this general psychedelic clinic where people of different ailments can come in, and then there's like a psychedelic or a psilocybin ward or like an MDMA ward or something like that?
Yeah, that's a great question. And as you know, those are currently undergoing FDA trials. But the evidence, I think there was a New England Journal of Medicine article looking at psilocybin versus SSRIs, and they found it was, really effective, as well as the MDMA studies with MAPS. So in the future, will there be a clinic, a psychedelic clinic, incorporating all of those different aspects? I mean, Mohammed, the fact that you're thinking about it, it might be you that's creating it. And this space is like crazy in that we're literally on the cutting edge right now. And so what we need are leaders and pioneers who have these visions of, hey, this is what I want to create. This is the way I want the psychedelic renaissance to occur. And so rather than, I love how you're looking forward into the future, is like, well, we get to create this. Like, I'm young, you're young, we're all kind of these young and up and newcomers. So we get to create the world that we want it to be. And that might look like a psychedelic center a clinical center where you have a group of psychologists, psychedelic therapists with all these different modalities and saying, oh yeah, well, studies have shown that for this type of depression, this subtype of depression, psilocybin is more effective, or this subtype, or this PTSD, maybe more MDMA. So yeah, I think that is very possible. The one challenge that I see right now, though, is looking at Spravato. And with Spravato, they have REMS. So that's like a risk mitigation component. And so there's a lot of restrictions with it, right? They have to watch the patient for 2 hours. It has to be a REM certified center. There's all of these regulations around Spravato. And what I also see happening with MDMA and psilocybin is once those become FDA approved, which I think they will be in the next 2 to 3 years, 5 years maybe, there's going to be restrictions. Like for example, with MAPS and the MDMA, like they actually have, I think it's like, they have a protocol, the MAPS protocol, where you have to do 12 therapy sessions. It's only, I believe, 2 MDMA sessions. There has to be a male therapist, a female therapist, and that's gonna have to be incorporated to allow them to get insurance coverage. And so that's, I would say, the regulations behind how it's being administered is going to be one of the challenges for sure.
And oh, sorry. Go ahead.
Oh, I just want to touch upon because we are in such a cutting edge space. Even with the Spravato, is a lot of insurance companies, they don't know how to bill for it. It's like, well, how do we bill for nasal ketamine? Because there's these other components, and it's like there is no CPT code for it. And I think there's going to be like this, the medicine is coming, but it's like, well, how is the health insurance company going to respond? What CPT codes are going to need to be created? How is the AMA going to play a role in this?
So with those challenges that you stated, do you think that your MBA or getting an MBA is helpful in navigating that? Or like, because I'm quite early in this whole path. I'm just now applying for medical schools, and I'm wondering kind of like the path of the accreditations I should acquire before like getting my skin in the game. What should I have on my name before I jump into this sea?
I mean, definitely start with the MD because you're going to need that. For me, when I started med school, there was no discussion of psychedelic clinics. There was no discussion of ketamine for off-label use. I was just personally interested in the business side and entrepreneurship. So I pursued a combined MD MBA program, which was great because it was only 5 years. Well, only, that's still a long time, but it was just nice because it was combined. And I believe for me, because I got it early on, like it did give me a bit of confidence to know like, hey, I understand finance, I understand strategy, I understand organization, leadership, accounting. And I knew that there was a deficit in medical education right now. Like I'd mentioned, like all we're taught is like biology and pathophys, but medicine is a big business. And I really believe that doctors, we need a business background, right? Or else if we're not leading the medical business, then it's going to be some MBA who doesn't know healthcare, or excuse me, who doesn't know medicine leading it. And there was a study that showed that hospitals that are led, that have CEOs who are MDs actually do better than hospitals that have CEOs without a medical degree. So if there's even an interest of like, hey, maybe I should get an MBA background, like for me, it was really helpful and useful. So I would highly suggest it and recommend it, but it's not necessary.
Thank you so much.
All right, I see Daria.
Hello, yes, can you hear me? Sorry about that. Yeah, thank you so much. I want to echo everyone's gratitude, Dr. Ko. I just wanted to ask if you would give us more insights and any anecdotes or thoughts about the strict contraindication of using ketamine in anyone with history of any kind of psychotic episodes or psychosis. And as we all know, medical and psychiatric histories can be quite ambiguous and hard to pin down sometimes, particularly in that realm, because we we have depression with psychotic features and so forth, and people sometimes have, to your point about the biopsychosocial, people struggle sometimes to articulate the quality and sort of the quality of their experiences and sort of reality and imagination and so forth. And so just have you had difficult situations where you had a patient who was desperate to try ketamine, or where something went wrong because someone had a history of psychosis, or just your general thoughts on that?
Yeah, great question, Daria. I just finished listening to a podcast by Tim Ferriss. I think he was interviewing Dennis McKenna. And I think one of my take-home points from that, and just reiterated again, was, the 4 S's. So we always talk about set and setting, but the other 2 are screening, set and setting, and then support. So talking about screening, it's really important because ketamine can be very effective. It can be transformational, but it's not for everyone. And a lot of these studies that have been done, they always screened out patients who had a history of psychosis or a family history of psychosis. And so at our clinic, I screen really rigorously. And so we had a patient who was, not doing too well. And when I did the consultation call, she tells me, hey, my brother has schizophrenia. My dad has schizophrenia. I don't personally have schizophrenia. And I said, hey, you're probably, there's a risk. And because the studies haven't been done, because they always excluded those patients who had that family history or personal history, like I tell them, there's a risk, and you're doing great, or you're doing okay now, but it could deteriorate where it does trigger into a psychotic episode. Personally, we haven't had any issues, again, because of that rigorous screening, but I have heard of other clinics and other patients who will get ketamine. And by the way, they forgot to mention that they have had manic episodes. And so there's been case reports and studies where someone will get ketamine infusions and it will literally trigger mania. And then because that's one of the things that it can cause. And there's definitely a risk there. So I think screening is really appropriate or very important. Collaboration with the psychiatrist is really important, and letting the patient be fully informed of the risk, the benefits, the alternatives, so that they can make a fully informed decision.
All right, Damien and Tallulah.
Hey there. What a great, exciting presentation. And I'm so happy that I'm very inspired by your work and what you've been up to. Dr. Cook, I wanted to ask you if you care to answer, have you used ketamine for yourself?
That is probably one of the most frequently asked questions that I get from my patients.
Yeah.
And I personally have not. And I know with different psychedelic substances, there's kind of 2 schools of thoughts on this, where it's like, hey, I'm doing MDMA therapy. I should personally have MDMA experience so that I can relate. But ayahuasca, for example, there's the shamans of Peru will drink ayahuasca as they're giving it because they want to be part of the experience. So I think that's about the history. Each medicine has its own history, right? So with ayahuasca, that's the history. With MDMA, that's the history. But with ketamine, the way it started was not that way, right? So when it was first discovered in 1964 by Dr. Stevens, Wayne State University, he wasn't administering ketamine to himself. He was administering it. Actually, he invented it, but his colleagues, they weren't administering it to themselves first. They were administering it to healthy subjects. And so ketamine has a history of being administered to other people, to the patients. And so I haven't personally partaken in it. And, it's kind of like the other school of thought is like, well, if there's an oncologist and they don't have breast cancer, do they need to do chemotherapy so that they can best know what chemotherapy feels like, so that the patients that they're giving chemotherapy, they can relate? And I would argue if they don't have breast cancer, then they don't need to be on chemotherapy, right? So similarly, if I had PTSD or I had TR, treatment-resistant depression, and I had tried bupropion and Prozac and Lexapro, yeah, I would definitely go for it. And I've recommended it to friends and family. And they may not come to my clinic because they live in Seattle or different places. I'm like, hey, give it a try. There's ketamine clinics up there. This is the one I would recommend. So it's just a different background and a different culture that ketamine therapy has arisen.
Yeah, I'm excited to be a part of a psychedelic group that's opening up a center here in New Haven with a lot of focus on the integration part. And my question was kind of coming from the place of like, we are in the business to help people that have many, many different elements and are deeply suffering. But I'm also very curious of the, like the relationship to just exploring your consciousness through medicine and through whether it's ketamine or plant medicines or psychedelics in general for healthy adults.
Yeah, I would say that's definitely the cutting edge for sure, right? So ketamine is currently being used off-label, right? We're using it off-label for depression. And then I think about something, I call it super off-label, where it's like, hey, I want to create a new song because I'm a musician and I'm doing great. I just need to get my creative juices flowing.
Yeah.
And because ketamine, it's a controlled substance, right? It's DEA Schedule 3. It's strictly monitored. And so each time we use ketamine, we're like logging it. And because it's strictly monitored, I really want to use it with integrity. And I feel like, ketamine clinics were kind of already on the cutting edge of therapy because it's off label. It's not, not super common, and it's becoming more aware, or people are becoming more aware of it. So to use it for these other purposes of like, hey, psycho-spiritual growth or creativity or, other things that may not be, because it's already not indicated. And so it would be even pushing the border even more, which might increase regulation from the DEA in the future.
Yeah. I did want to ask about, my most of my experience is just with intramuscular. So I'm very curious about the IV drip. Do many people in your experience ask to come out?
I would say less than 1%.
And the very few that do, what's that like for them? That sounds like a interesting place to be.
It's scary. It's pretty scary. So
Yeah.
they're like 20 minutes in, and they hit this tipping point, and then they'll have they'll start having a panic attack, and they're breathing fast, and they're like, where am I? What's going on? And especially people who are not familiar with that kind of state, with that psychedelic state, it can be scary, especially because it's the mind and the body it's dissociating, and their ego, they feel like they're dying. And so, yeah, it can be pretty traumatic. I feel like, kind of preparing the patient beforehand can be really useful. And I tell them like, hey, it might get scary. You may feel like, at a certain dose, you may feel like you're going to die. Mm-hmm. And I tell them, I say, hey, if you experience that, go towards it.
Lean
go
in.
straight towards it.
Yeah.
And I say, it may feel that way, but trust me, I'm watching all of your vital signs. I'm looking at your blood pressure. I'm doing continuous cardiac rhythm. I'm going to let you know if there's something concerned, but I want you to just trust and go with it. And because I've developed that therapeutic relationship beforehand, and they trust me, and there's a medical setting, I feel like patients are more willing to let go and surrender into that.
Yeah. Awesome. I appreciate your response and being here.
Yeah, you're welcome.
All right, Fabiana.
Hi, I thank you for facilitating this session. I have a question around, I'm curious if you partake in any advocacy or coalition work to help move the needle for state-based regulations on the legislative landscape. And really curious to find out what has been productive to help maybe eliminate some of the red tape when considering the future of making this less illicit.
Are you referring to ketamine or for other psychedelics?
I think other psychedelics in general.
So I know so we're in California, and I know there's been several bills, at least from a local level, like Oakland, California example, where they've decriminalized all psychedelics, I believe, and also in Oregon and I believe Colorado. So this is happening. There's a concern though, as physicians, we're bound by certain rules and regulations, right? Like to get a medical license takes a lot of work. And I would say that there is a challenge of promoting things that may not be approved quite yet. And so, I think about, let's say like Portland, Oregon, psilocybin is legal or decriminalized, right? So there aren't probably a lot of clinicians jumping on board like, hey, I'm going to start giving psilocybin, right? And because they have their medical license on the line, and there's with psilocybin, it's depending upon which mushroom you get, it may have different concentrations. So it's really hard to like get an accurate dose. So there's some challenges with that. I think overall though, like just the evidence is going to be key. Like Johns Hopkins, the Center for Consciousness and Psychedelics, more data becomes available, that's going to be crucial. But I don't think data's the full story or the full thing that's going to move the needle. I think what's really going to move the needle and what's always moved the needle are stories. So patients telling their stories or you telling your story of like, hey, this is how it helped me. Because that's what really moves the needle, because I think data is supportive, but people aren't moved by data. People are moved by emotions and justify it with data. And the way we transform emotions is via storytelling, because humans, we're storytelling creatures. For 100,000 years, we've sat around campfires, told stories, and that's what motivates and inspires people, not p-values less than 0.5.
Okay, thank you.
All right, Rob.
I'm going to double dip on this Q&A. Thank you very much again. Loving the Q&A. So thanks for the questions and thanks so much for the answers, Dr. Ko. You kind of teed up my next question here perfectly. It's a very general question, but more like, I'm just curious, what are the big surprises you've had, positive or negative, pleasant or unpleasant, over this whole experience, whether it's been patient outcomes or whatever other things that have surprised you, some stories that you might have to share.
Yeah, it's a great question. One of the themes that I've been getting more and more is ketamine and these other substances are just one part of the therapy. And I really believe that it's the clinician who's administering it that plays a key role. And for the clinician who's administering it, they really need to know why they're doing it. They really need to know their intention. And I also think there's this part, this might sound cheesy, but this part of just unconditionally accepting and loving the patient as they are, right? You may not have to state it, like drastically, yeah, I love you, but just this feeling that the patient is receiving, because I feel like a lot of people, like we don't get that in their lives. And just to have someone there sitting with them, paying attention to them, can be incredibly therapeutic. And, there was a study where they looked at all these different types of psychotherapy, like CBT and Adler and just all these different modalities. And they were trying to compare like which of these are like the most useful. And what they found in that study, it's an old one, that the majority of the therapeutic benefit came from the relationship between the provider and the patient. And so how this ties around to the ketamine therapy is, it's like, yeah, the ketamine, it's amazing and it's super helpful. And it's the doctor that's actually making an impact. So just being really conscious of that and like, hey, what's my energy like? Who am I being? What's my presence like? Like that seems to be playing an integral role in the ketamine therapy. And that's some of the feedback that I get from my patients. They'll come from other clinics and they'll have the experience here and they're like, wow, that was just completely different. And, I think there's a component of that relationship of this unconditional regard and acceptance and love for the individuals.
Sorry, I muted myself and then it's this whole process of getting unmuted. I just say, That was an awesome answer. Very much what I was hoping to hear without even knowing it. So you put words to something I've definitely been thinking about. And I love that that's what you've been experiencing and coming to realize. Yeah, awesome stuff.
Yeah. And for all the medical people out there, like, even if you're not doing ketamine therapy, even if you're just having a daily interaction with the patient, still bring that energy into the space. And they may be coming in for chest pain, they may be coming in for abdominal pain, they may be coming in for whatever issue. Like, we can still hold that space for the patient. Just this unconditional, loving, regarding, accepting space. And for whatever issue, it just seems to just add a little bit something extra. And as I was speaking, I did want to comment on the previous question about the advocacy component. And I forgot to mention this, is the Religious Act. And I know that this is one of the workarounds where psychedelics like ayahuasca, for example, is actually becoming legal. So classic would be Santo Daime Church or the UDV Church in America, where they're coming from the background of religious freedom, bringing it into the United States and saying, hey, this is part of our religious practice, and that's being allowed. In addition, the Native American Church with peyote, because it's part of their tradition and culture, they're able to access it legally, and it's gonna, it's federally approved in that situation for those religious freedom components.
I'm curious to know, what was the hardest part of starting this clinic? I can imagine it wasn't a very easy journey getting this thing up and running. So
that's a really good question. So I've been, when I met Rob 5 years ago in 2016, this was not even like the clinic didn't even exist. And it took 2 years for me to actually do it. Right. And I just made up an excuse like, hey, I need to read one more paper, or hey, I need to do this, or hey, I need to do, have everything prepared before I actually do it. So I would say taking that first step of doing it and committing to it, because there's a huge activation energy in starting something up. And I would say once I took that first step of like really committing myself and saying, hey, this is going to happen. And I would say that turning point was, putting skin in the game, right? When I signed that lease and I'm like, crap, this is real. And hey, here's $50,000, like build this out, like that's real. And it takes courage. It takes a lot of courage. And, I would say the reframe that I had about that is, life is an adventure, right? So imagine if you go to Las Vegas and you play, and let's say that in this imaginary Las Vegas, you're going to start winning every single game. You're going to play blackjack, boom, every time. You're going to play slots, boom, $1 million. And at a certain point, it's going to get boring if every single thing we know is going to work out. So if we can embrace this idea of the unknown and the possibility of it failing, like, hey, I might open this clinic up and it might fail. And that's actually the adventure. Like knowing that it may not work and embracing the risk and saying, hey, I might just lose a bunch of money, and still doing it anyways. And for me, that's actually part of the enjoyment of like, hey, this is scary. Like this is out there, but it just adds to the adventure and spice of life.
I love that view. All right, Mohammed, I see you got another question. Well, actually, I might pick on Savannah since she hasn't gotten to ask one yet. We'll come to you next, Mohammed.
I'm not sure if anyone already asked this, and it kind of goes into what you're saying, but I was wondering if you had any backlash from the medical community or your colleagues for starting.
That's a really good question. And yes, 100%. Like when I first started thinking about it, I started getting made fun of because my last name's Ko. They would start calling me Ko Ketamine, Dr. Ko Ketamine, are you going to give more ketamine? And so there was a little bit of like kind of good-natured ribbing, I guess. So that was like the minor stuff that I didn't really mind. But once I started getting myself out there, I have a post on White Coat Investor, which is like this kind of a large blog for physicians. And I put a post on there like describing my experience. And I was reading some of these comments, and they were like hate comments, like, hey, you're just like, another cannabis provider, and just all these hateful comments. And there's definitely a backlash. And kind of the reframe about that is that, has been helping me is like, anytime someone is doing something different, we're going to face backlash. And the best example of this that I can give is back in the 1800s. There was a physician, his name was Dr. Semmelweis, back in Vienna General Hospital. And there was something called childbed fever, puerperal fever. And one of the reasons that was occurring was the physicians, med students, they weren't washing their hands between gross anatomy lab and delivering babies, right? And so Dr. Semmelweis said, hey, let's wash our hands. Here's my idea. And he started doing that at Vienna General Hospital. The maternal mortality rate dropped. And he's trying to tell his other colleagues, hey, all you need to do is wash your hands. It's going to make a big difference. For 40 years, they all ignored him and they called him a freak. They're like, no, that's, you're bogus. That's not the reason why puerperal fever is happening, XYZ. And, now, of course, we know, yes, you want to wash your hands between anatomy lab and delivering babies. It's obvious. But initially, when it first came out, there was a lot of resistance. And in medical community, medicine is slow to change. I remember learning in school, medicine changes one funeral at a time. People get stuck in their beliefs. People get stuck in kind of their default mode network and their training. And so what I've personally experienced is there has been backlash, especially with people who may be further out of training. They may not be more aware of the evidence. And I've noticed that the more younger physicians, the more people who are up to date, they are open to it because they have seen the articles and they're looking at the data and they're open to it. And I think just being cognizant of like, yeah, this is going to happen. If you're going to start up a ketamine clinic, you're going to face backlash. And that's part of, doing something different. That's part of, standing out and be willing to also embrace that challenge as well. And because at the end of the day, I'm not catering or serving those physicians, those psychiatrists. That's not my patient population. I look at my patients and I see the changes they've made and they tell me, hey, Dr. Ko, thank you so much. You've made a huge impact in my life. And I get Christmas cards now. Like when I was in the emergency department, I never got Christmas cards or like, cookies. And now I'm getting those baked. And I'm like, wow, this feels kind of nice. Like I'm getting, handmade, homemade cookies. And it's like, yeah, I know I'm making an impact. It's not for everyone, but for the people that we can make a difference, like those are the people that I want to focus on while acknowledging and accepting the backlash that's naturally going to occur anytime I do something differently.
I can't believe you weren't getting cookies in the emergency department. All right, Mohammed.
First off, thank you, Rob, for giving me the courage to double dip. So the risk in starting your own practice, you saying I gave 50K and, signed the lease and that's terrifying and whatnot. So there always has to be a financial security component before jumping into this. So once you finished your residency, did you start out working like those large healthcare companies that you talked about, or did you kind of just like jump into starting your own practice? Because one of my main fears is working for large healthcare companies and then feeling like I can't leave, kind of feeling like stuck in it, so yeah.
Yeah, that's so I finished my residency in 2011 and I didn't open the clinic until 2018. So during that 7-year period, I did work for large healthcare companies. And as a matter of fact, right before or a few years before I opened up the clinic, I was an associate medical director of an ER. And they were like, hey, Sam, we want you to be the medical director. And that would have come with a lot more money. It would have come with that, job security. But I realized that wasn't for me. And so there's this saying like, whenever you're climbing a ladder, make sure that it's up against the right wall. And when I saw the ladder that I was climbing and I saw the people ahead of me who was, hey, I'm the regional medical director, and hey, I'm the vice chair of this, like that just didn't resonate with me and who I am. And our lives are so short and brief on this planet. it's like, hey, yeah, I'm gonna live 80 years, I'm gonna live 90 years if I'm lucky, right? And for me, this concept of death and like this preciousness of our life, and we have like literally a blip in life. Earth has been around for like what 4.5 billion years, and humans have only been around for the past whatever, like 200 million years or however many years, and my life is only just 80 years, right, in the grand scheme of things. And knowing this preciousness of life and what I want to do, what I'm passionate about, that's what really motivated me, is like, hey, life is short, I want to do what I'm going to do. And then for that financial security, because it's real, I mean, student loans are real. I think the average med student graduates with 250K of student loans. So we're almost like indentured servants. So yeah, for those first 7 years, like I worked my butt off, paid off my student loans. And even when I was starting up the clinic, it wasn't like, hey, I'm done with ER. Like I continued working for these healthcare corporations part-time though. So what I was initially, when I started, I was doing like, 2 to 3 shifts in the ER per week. And then I was doing 1 to 2 days of clinic. Because when I first started the clinic, it's slow and not a lot of patients. And as time progressed and the patient base builds, then I was tapering the number of clinical shifts up until 2020 with the COVID-19 pandemic, with our baby being born. I decided to, step out of the ER completely for now. I mean, things may change, and just focus 100% on the ketamine. But yeah, you definitely have to consider your finances. And yeah, you have to, sometimes you may work for a large healthcare corporation, but you don't have to necessarily do that full time. The other component is to keep, this is more of a practical thing, is just keep your living expenses, or I kept my living expenses low, right? So when I graduated residency, I know some people, they're like, hey, I graduated residency, now I'm gonna go buy the Tesla Model X, and I need my doctor house, and I need, XYZ. And for me, I didn't do that. I continued driving my Honda Accord. I, bought a small place. I kept my expenses low. And because I kept my living expenses really low and living frugally, then I had space, I had time, I had extra money, so that I wasn't making monthly Tesla payments. So I think the key is to do it, do it wisely, financially wise, where you're able to taper down clinical shifts. You may be working for a large healthcare corporation, but then you can also gradually increase the private practice for the ketamine side, or, in the future, MDMA or psilocybin or whatever may come out.
So insightful. Thank you so much.
All right, anyone else have any questions? I think we're basically running up on the end of time right now. I think maybe this is probably a good place to wrap things up. I will unmute everyone and let everyone say their thank yous to Dr. Ko. I don't know, Dr. Ko, do you have any parting words, any last things you'd like to say?
I'm just so grateful to be able to present and share my experience with you. This is William, Rob, Yale Psychedelic Science Group, like just super grateful. And you guys are also, you all are being courageous and even starting up an organization like this. So wanted to just acknowledge you and give you a shout out. Like, thank you so much for the work you're doing. And, we are the change, and we can be the change. And I think this is living proof of it. So thank you so much.
All right, thanks a lot. I'll unmute everybody. If you feel so inclined, you can shout out a thank you.
Thank you.
So much.
Thank you
Thank you.
so much.
Appreciate your insight.
Bye.
Thank you. Have a good evening.
Bye.
Thanks so much, Dr. Ko, and thank you all.
Bye, everybody. Have a good night.
Bye.